The importance of removing all the osteophytes circumferentially can be appreciated now that there is a round humeral head. With the head exposed, anterior, posterior, and then inferior-superior measurements are taken. When using the templates, first measure the anterior-posterior curve, as this is the measurement that defines the reamer that will be used for the head. Using the templates, assess both the one that best matches the curve of the head, as well as the size of the template from end to end. The best size is determined by the optimal match of the feet of the template on the anterior and posterior borders of the head. Dr. Uribe selected a 48 on the AP, which interestingly is the same as his left shoulder. For the superior-inferior, this patient is a 52, which confirms the 4 mm offset between AP and SI. He places the trial and centers it on the head as he will shoot the centering pin through the middle of it. The system allows placement of the pin by using the trial or even the reamer. Once the centering pin is inserted, the next step is to insert the centering shaft. Centering the pin on the head and placing the centering shaft at the right height are the two most important steps in the procedure. The pin determines where the implant will be located on the head, and the centering shaft determines the height of where the implant will seat. The centering shaft has several etch marks on it. Each one is a step of 1 mm. If the head is not flattened out significantly, the centering shaft can be placed so the shoulder is flush with the humeral head surface. If, however, the head is flattened, then it is best to leave the shaft up at least 2 mm, so that you don't over-ream the head and go past the anatomical neck. The reamer gives you a visual cue, as you want to finish with the reamer level with the anatomical neck. If you see that it is not going down far enough, then you can simply take the trial handle, place it on the centering shaft like a T-handle, and then advance the centering shaft down 1 mm at a time. The beauty of the system is that the reamer is defined by the AP measurement, whereas every other system uses the SI measurement, which is larger. This means that the other reamers are bigger, resulting in a greater risk of reaming into the insertion of the rotator cuff. This is why other resurfacing implants tend to be placed in varus, as you will tend to cheat the reamer inferiorly to avoid damaging the rotator cuff insertion. To provide a little more space when reaming the glenoid, Dr. Uribe uses the crown reamer over the centering shaft to take off another 2 mm from the top of the head. It doesn't seem like much, but this can be the difference between reaming and hitting the head or reaming without any obstruction. Now that the shoulder is reduced, he uses a Fukuda retractor to move it out of the way. The larger Fukuda may be better, as it allows the humeral head to penetrate through the opening of the Fukuda, and you will see where that will come into play when we prepare the glenoid. At this point, Dr. Uribe moves onto the glenoid, and then once the glenoid is in place, he will come back and prepare the head for the humeral OVO hemicap. Next, using the bovi, he separates the labrum from the glenoid. This essentially is a capsular release, which is performed circumferentially. It significantly enhances mobility, especially in those individuals who have had restricted motion for years because of osteophyte formation and head deformity. As you can see, these tissues have become very contracted. It's easy to do a circumferential release of the labrum as it does not cause any further instability. With this exposure, he is able to easily place the glenoid guide. One of the little pearls of placing the Fukuda in there is that you take the Cobb elevator and you elevate that posterior labrum off, which allows the Fukuda to be placed between the labrum and the glenoid, providing much better retraction posteriorly of the humeral head. The guide is the exact size of the implant, so Dr. Uribe prefers to place it slightly more posterior, as he reams more anterior. Here it's fairly well centered. Now he drills in the guide wire until the single etch mark is level with the shoulder of the drill guide. It's easy to remember that the single line is the reference mark for the single circle glenoid, and the double edge is for the double snowman-shaped glenoid implant. The guide is then removed, and the glenoid reamer is then inserted over the guide wire. You may notice here that the reamer may strike the humeral head before getting down to the glenoid bed, possibly notching the humeral head. This is not an issue, as the head will eventually be covered with an implant. If the channel you ream is significant, it can always be filled in with bone chips prior to final placement of the humeral implant. It is important when reaming not to rely on the guide wire coming into the back of the reamer window, but instead watching the glenoid vault until you see full circles start to appear in the bone bed. The reason for this is because the guide wire may advance into the bone as you ream, and so you may ream too far into the glenoid. The goal is to have the trial be slightly recessed to the edges of the surrounding glenoid bone. In this case, the procedure is the single glenoid, so now Dr. Uribe moves on to prepare the central peg hole. Using the flexible reamer, place it through the central hole of the trial, and then ream down until it can't advance any further. A trick here is using a hemostat. Place it into the reamed peg hole following reaming so you can enlarge the hole slightly. This helps later when placing the glenoid into the cement, because the peg will go into the central hole more easily if it is slightly enlarged. The next step is to prepare the glenoid vault for cementing. The set has an awl that is designed to create a series of cement channels around the glenoid bone bed. Once the channels have been made, a silicone finger sleeve is provided so you can pressurize the cement in the bone bed without having it stick to your glove. Once the cement is in place, we place the polyglenoid onto the suction handle and then place it into the vault. Using finger pressure to set it into place. If you don't want to use your thumb to hold it in place while the cement cures, you can use the suction handle to apply pressure. Finally, remove the excess cement. Now that the glenoid is complete, Dr. Uribe moves back to the humeral head to finish placement of the OVO humeral head. In this patient, Dr. Uribe could have used the larger snowman glenoid. However, he found that the single disc works very well. It covers greater than 50% of the glenoid surface, and if placed inferiorly, where the majority of the wear normally occurs, it will essentially cover the entire part of the damaged glenoid. The humeral head is dislocated and exposed into the wound. He chooses the trial from the original measurements, 48 by 52, and places it on the head, taking care to assess version and placement. The trial is secured in place using a couple of threaded pins. In this patient, there was some advantage in determining the size, as his left shoulder was done approximately 2 months ago. The patient demanded that the right shoulder be done as well, as he had such excellent function on his left side. Dr. Uribe drills the pilot drill through the handle until the etch mark is level with the top of the handle, and then he leaves it in place. Now the handle is removed, so the step drill can be used. It is important here not to depend on the reference of seeing the pilot drill in the window of the step drill, as the shoulder bone can be very poor and the step drill may push the pilot drill deeper as you ream. Instead, use the reference off the shoulder of the step drill until it is level with the collar of the trial. The next step is to tap, using the same reference etch mark level with the trial collar. Now with the screw bed prepared, Dr. Uribe docks the screw in the end of the handle before placing it into the trial. He screws the handle back into the trial to get it started in the hole. Using the screwdriver, he now advances the screw to the right level by taking the shoulder of the screwdriver to the top of the handle. Using the depth gauge, he checks the height of the screw, confirming it's not too high or too deep, so that the trunnion and taper will lock together properly. The final step is impacting the hemicap OVO implant on the head. Checking the circumference fit around the head to make sure it is completely seated on the humeral head. Here you can appreciate the relatively small incision and see the head articulating with the inlay glenoid. The cephalic vein has remained intact, so now he reapproximates the subscapularis tendon and closes the skin.